I am Dr. Jeff Burns from Children's Hospital in Boston and Harvard Medical School, and I'm very pleased to be joined tonight with my colleague, Dr. Jessica Moreland. We're going to begin with a segment with two of the senior authors of the most recent publications on the epidemiology of MISC, Dr. Mike Levin and Dr. Adrienne Randolph. And then finally, we will also be hearing from experts on therapy. Colleagues from the American College of Rheumatology guidelines that have recently been published are here tonight to explain their thoughts on therapy for MISC. I'm going to turn now to our colleague, Dr. Mike Levin in London, who's staying up very late once again to join us. Mike, I'm going to turn this over to you.
Thanks very much, Jeff. Hello, and thanks again for asking me to join this meeting. I'm going to try and describe what we have learned about MISC following the really amazing explosion of new literature in a very short period of time. It seems remarkable that it's only 4 months since at the end of April there was almost simultaneous alerts from the UK, Spain, France and Italy of new or upsurging patient syndromes as each country experienced the COVID pandemic. And the alerts covered a range of syndromes from Kawasaki disease, myocarditis, and shock. It's also remarkable that the journals have been able to publish so rapidly such an extensive literature, initially case reports, then larger series. So we now have quite an extensive literature on the disease appearing in a very short period of time. The first descriptions of the relationship between COVID-19 in timing and the upsurge of Kawasaki disease were from the Italian and French literature shown on this slide. And that documented clearly that there was genuinely an increase in the numbers of patients meeting the case definition of Kawasaki disease occurring some weeks after the COVID-19 epidemic arrived in each country. From intensive care units, and this is an example from the UK intensive care network, there were reports of patients arriving in intensive care with shock, with syndromes that looked like toxic shock syndrome or Kawasaki disease shock syndrome or macrophage activation syndromes. And this slide shows in the blue line, go back to the one, the blue line shows the expected numbers of patients with myocarditis, toxic shock syndrome, or macrophage activation syndromes in each week, as against the green line, which was the actual numbers of cases occurring in UK intensive care units. What these different reports raised was the question of whether we were seeing a whole range of different disorders, all occurring around the time COVID was arriving in each country. And in the editorial to the two major papers describing the experience in the United States, I used the analogy of the blind men feeling the elephant, different parts of the elephant and each of them declaring that the whole beast was represented by the part they were feeling. And so where were these reports of Kawasaki disease, toxic shock syndrome, encephalopathy, abdominal disease, all different diseases, or were they one problem? So the question I'm going to try and address is, are the different reports describing a single entity or separate disease associations? What is the relationship of the new childhood disease to SARS-CoV-2 infection? What is the epidemiology of this new disorder? What can we expect in the coming mechanisms, and what is known about mechanisms? So are we seeing a set of unrelated inflammatory diseases, or is there a single disease with varied manifestations? We attempted to address this in the report from the UK, published in JAMA, by looking at the range of different manifestations that each patient suffered. And what we looked at is which patients met Kawasaki disease criteria, had fever and inflammation, had shock, or had gastrointestinal symptoms. And what we appeared to be seeing was 3 different phenotypes. First of all, shown in green, there were patients that were not critically ill. They did not have the diagnostic features of Kawasaki disease, but they had intense inflammation and persistent fever, often with abdominal pain. And then there were a group of patients presenting with shock, multi-organ failure, and with a very high proportion of them having myocardial involvement. And then in yellow, there were patients meeting the complete definition of Kawasaki disease. Of note is that coronary artery aneurysms were observed in all three groups. The report from the California MISC response team, published in MMR recently, did a similar attempt to define the spectrum of disease, and they used latent class analysis, which is a statistical approach which lets the data classify the patients, and they described three different classes of disease. First of all, in red, there were what they called class 1 disease, where the predominant feature was shock and multi-organ involvement, often with myocarditis. They had raised troponin levels, they had raised BNP levels, they had a high incidence of coronary artery aneurysms, and usually these patients were serologically positive for SARS-CoV-2 antibody, but negative for PCR. Then the class, what they termed was class 2, shown in yellow, were patients with predominant respiratory presentation with cough, dyspnea, pneumonia on X-ray, ARDS, and these patients were largely PCR positive for the virus and often negative for antibody. And then there was class 3, shown in green, where the predominant feature was rash, fever, mucositis, and often meeting the criteria for Kawasaki disease. And these were largely serology positive, but also a third of them were PCR and serology positive. And these three classes were distinguished also by the laboratory findings in terms of troponin levels, fibrinogen levels, BNP, and so on. So we seem to be seeing subclasses or subgroups within the disease defined by the data. We attempted to see how the new syndrome differed from Kawasaki disease as we knew it before COVID-19 by comparing the UK patients with MISC, or PIMS as it was called in the UK, with the unique database of Kawasaki patients. Jane Burns's group in San Diego had over 1,000 patients with Kawasaki disease on their database, and also patients with Kawasaki shock syndrome. And we were therefore able to do a comparison between the new disorder and Kawasaki as it existed pre-COVID-19. And this is a complicated slide. The red arrows point to the MISC patients. And really, to summarize what is in this table in the paper, the MISC patients differ from Kawasaki disease or Kawasaki shock syndrome in being older age, having higher neutrophil counts, higher CRP, higher ferritin, higher troponins and BNP levels, but lower lymphocytes, lower albumin, lower hemoglobin, and lower platelets. So looking, although remarkably similar in some of the patients to Kawasaki disease, like a distinct disorder. We've also attempted to ask the question, how easy is it to distinguish MISC from other infectious and inflammatory diseases with raised CRP and elements of inflammation by comparing the MISC patients shown in red arrows with over 2,000 patients that we have in the Euclid's database, which is a European funded study we participated in some years ago, which recruited febrile children across Europe. And this is work still in progress. This is unpublished data that Claire Wilson is analyzing. But what you can see is that the red arrows point to the MISC patients. They have higher CRP levels and lower lymphocyte counts than an extensive range of patients with bacterial infections, viral infections, and other inflammatory diseases recruited over a 5-year period of time. So concluding the clinical spectrum, it appears that we are dealing with a single disease, but with a very wide spectrum. They have in common fever and inflammation, but there is a range of presentations, including presentations resembling Kawasaki, atypical Kawasaki, myocarditis, shock and multi-organ failure. but coronary artery dilatation or aneurysms can occur in all the groups. There also appears to be an overlap between acute COVID-19 and MISC. The laboratory features are distinct from Kawasaki disease, and particularly there is a higher CRP and a lower lymphocyte count than in other febrile illnesses. But I think we have to conclude we have real difficulty in distinguishing this spectrum of diseases from many other childhood febrile conditions, because there is no diagnostic test and because there is no absolutely defining clinical feature which is unique to the new syndrome. Turning to the relationship between MISC and SARS-CoV-2 and COVID-19. The first clue was that there is a time gap between the upsurge in cases of MISC and the upsurge of cases of COVID as the pandemic evolved in each country. And this is the UK data, where it appeared that MISC was lagging approximately 4 weeks behind the COVID upsurge. There was remarkably similar findings from the two studies in the United States, Elizabeth DeFort's study and Laura Feldstein's study. The New York data on the left shows the MISC patients in red bars, the blue shows COVID-19, and we can see again about a 4-week difference between the rising cases of COVID and that of MISC. Should also note that the numbers of COVID-19 cases are in hundreds, whereas the numbers of MISC patients are in single units, indicating a very marked discrepancy between the frequency of the two conditions. And similar, the findings across the United States in the Feldstein study. Also in the map below, showing that the MISC is occurring at the same sites that we're seeing high numbers of cases of COVID-19. So the disease seems to be occurring a month after COVID appearing. And a very similar finding in the French epidemiological data, again showing a 4 to 5 week delay in MISC appearing after COVID, but also showing on this slide that as the disease as COVID came under control in France, the incidence of MISC declined markedly, and that's continued, and also showing that the MISC occurs in the same hotspots where COVID-19 is occurring. So I think from the epidemiology, we can conclude that MISC is a disease that's related to the epidemic curve of COVID-19. It occurs approximately a month after the epidemic peak. Most cases are negative for virus, but positive for antibody against SARS-CoV-2. We can therefore expect MISC to be rare in countries where the pandemic is controlled. MISC will continue to be a serious problem in countries where the pandemic remains uncontrolled. And I think the implication is that this is a disease that is prevented by the public health measures that control COVID-19. Coming to mechanisms, and here we really have to say that we don't know what the mechanism in this disease is. But the really strong clue is the timing, that this is a disease that's not occurring as the virus is present at high frequency in the body. It's occurring at a number of weeks after the infection. Most patients have already cleared the virus when they come in and are antibody positive. And therefore, as shown on the slide, we would suggest that most children who have a normal immune response will successfully clear SARS-CoV-2 with either asymptomatic infection or minimal symptoms. And then, for reasons that remain to be understood, those with a different type of immune response end up with an inflammatory response that, as you develop T cell and antibody immunity, somehow induces an inflammatory process. And this results in the febrile child with an elevated inflammatory response, the full spectrum of MISC, and the Kawasaki-like disease. And there is growing evidence that this may be mediated by antibody or by T cell. In the case of antibody, there was very good data from SARS-CoV-1 that antibodies against the spike protein are able to trigger macrophage activation. There is also recent papers in SARS-CoV-2 that immune complexes are able to cause macrophage activation. And it's interesting that immune complexes are well described in Kawasaki disease. So coming to the last few things, we seem to have a good description of the disease and its manifestations epidemiologically. We have a desperate need to understand the biology of the disease better. And the papers that are beginning to appear, this is from Gruber and et al., a bioarchive paper, so not yet peer-reviewed, showing that MISC can be distinguished on a whole range of immunological features from COVID. So we have a long way to go in understanding this disease, and really we need patients to be enrolled in biological research studies so that the research teams have the samples to look at to unravel this disease. And the last thing before opening for questions is there will be a session later on treatment of the disease, but it's clear that up till now, treatment has been guided by our best guess, by whether we thought the disease looked like Kawasaki disease or toxic shock or macrophage activation. And we've chosen immunological treatments that have worked in other conditions, but we desperately need randomized trials, and these are going to take a long time to become available. However, because we have a very large number of children already treated based on each clinician's best guess, it is possible to enroll patients that you've already treated into this international study called the Best Available Treatment Study, which aims to compare the rate of improvement in inflammatory markers and their outcome in your chosen treatment by comparing the rate of change of inflammation and the clinical condition and using propensity matching to control for the severity of disease. And I'd really appeal to everyone who's experienced this disease in any country to join the study. It's a truly international study. It's an online web-based enrollment. It has de-identified data, and already there are 122 sites in 33 countries who've joined the study, and we hope will be enrolling patients. And all clinicians who join the study will become part of an international BATS study group. So last slide, I just want to end by saying that the data from the UK that we presented has been a huge collaboration of clinicians in multiple hospitals and different research teams, and to acknowledge our research team at Imperial College, Jane Burns's team in San Diego, and all our colleagues who've made data available to us. So thanks very much, and happy to take questions.
Mike Levin, thank you for that wonderful overview.
For this next section, we're going to focus on what is known about the treatments for MISC. And today we're very fortunate to be joined by a panel of real experts in the area. All of the panelists tonight are part of the American College of Rheumatology task force that has laid out some guidelines for thoughts on treatment of MISC.
Thank you very much. We are going to talk about treatment in MISC. And what we want to do today first is to just review a little bit about the methodology that we used on the task force for the American College of Rheumatology. So I'm going to speak to that briefly. So the ACR, the American College of Rheumatology, convened this task force. The idea was to provide expedited clinical guidance on MISC to clinicians who are seeing pediatric patients with this condition. This task force was convened in May. And the recommendations were made in June. So certainly there's been additional publications since that time. The target audience were American College of Rheumatology members in North America, pediatricians and other clinicians, but certainly there is a need to provide guidance to people in less resource intense settings. The primary products were clinical guidance recommendations for MISC. It's important to note that these are not traditional guidelines that the American College of Rheumatology uses. That is a very vigorous process that involves a lot of evidence review. And obviously with MISC, there was less evidence available, and we wanted these guidelines to be made available very quickly. And so these are not traditional guidelines, they're termed guidance. So this guidance is based on the scant evidence that has been available for MISC. It's certainly not meant to replace best clinical judgment and decision-making with the patients. And this was a living document that is expected to change over time. And a manuscript reporting on these guidance is published in American Arthritis and Rheumatology and is available for review. So the members of the task force were selected based on their expertise in Kawasaki disease and macrophage activation syndrome and cytokine storm related syndromes. The panel included 9 rheumatologists, 2 infectious disease physicians, 2 cardiologists, an ICU, critical care specialist, and 2 adult rheumatologists. Also of note that over time we've really recognized, as Adrian mentioned, the involvement of the nervous system, GI involvement, hematology involvement, and also the importance of expertise from emergency department physicians, and that this type of expertise will hopefully be incorporated in future iterations of the guidance. And so the methodology that was used was a modified Delphi technique. The task force was broken into 4 work groups. We developed evidence reports and preliminary recommendation statements. The entire task force was asked to vote on each recommendation statement. This voting was done anonymously and asynchronously through email. And each statement was voted on using a 9-point scale of appropriateness. After the voting, there were 2 webinars used to discuss the outcomes. And finally, the guidance statements were created and drafted, and everyone on the task force had input on the final document. Statements that were approved had to have high appropriateness ratings and high levels or moderate levels of consensus. And so the result was 40 guidance statements that covered diagnostic evaluation of MISC, cardiac management of MISC, and treatment of MISC. And today, during our question and answer session, we're going to focus on treatment of MISC. Okay,
thanks so much for giving us the overview. I mean, it really is such a totally different time for all of us to try to be figuring out treatment to a disease as it evolves before our eyes. And we're lucky to have so many experts in inflammation with us tonight. I'm going to send the first question to Dr. Mehta, and really thinking about when should immunomodulatory treatments be started in MISC? Should the diagnostic evaluation be fully completed before this is started? And is the timing different in patients who present with shock and really life-threatening manifestations? We have one patient on ECMO in our ICU right now in Texas.
Yes, I think it's useful to take a step back and think about diagnosis. And I echo everything that Mike Levin said about 2 things. So really considering alternative diagnoses and looking hard for bacterial infection. We've had some reports of patients who ultimately had leukemia who were treated for MISC. And so really thinking thoughtfully about other diagnoses. And then the benefit of a multidisciplinary approach. So we've had good success at CHOP at having a daily call between rheumatology, the PICU, cardiology, infectious diseases on any patient who has suspected MISC, and that's been really nice with getting each service on board to kind of give their opinion. So in our document, we didn't tackle creating diagnostic criteria because that's a pretty time-intensive process, but we did come up with a diagnostic algorithm, and we required that patients have a link to SARS-CoV-2, either PCR or antibodies or a history of exposure, and then 2 clinical features. And so some of the Kawasaki features, but then the neurologic symptoms that you mentioned, Jess, and then some GI symptoms. And then if a patient had an epidemiologic link and some of those features, then we consider them under investigation. If they were in shock, then we recommended doing the full diagnostic evaluation. And if they weren't in shock, then we thought about we sort of set it up as a tiered approach. And so sending some basic labs, CBC, Ceterate, CRP, CMP, SARS-CoV-2 PCR and serologies. And if a patient was inflamed and they were either lymphopenic, had a low platelet count, or hyponatremic, hypoalbuminemic, or a high white count, then you went to the second tier evaluation, which is BNP, troponin, procal, and things like that. And so if a patient was stable, really felt like they could undergo that full diagnostic workup, and if they had suggested features based on that lab workup, then we thought at that point treatment made sense, and starting with a single dose of IVIG. If they were in shock and really hadn't been able to get to that full treatment, and maybe we hadn't ruled out bacterial causes and things like that. Even then, there's some probably it makes sense to potentially treat that patient with IVIG at that point if there are some suggestive features of MISC. And then in terms of the steroids, I think there's some specific questions about that later on. But if a patient didn't necessarily respond to that first dose of IVIG, or they were in a little bit more critical condition, then and they were being covered with antibiotics, if bacterial infection hadn't been ruled out, then we thought that adding on steroids would make sense at that point as well.
I wonder if I could follow up. We heard a wonderful kind of discussion from Mike Levin and Dr. Adrian Randolph about what is this entity. And a question for the panel here. I noticed in your guidelines, you didn't comment on do all patients with MISC, do all patients need treatment? I wonder, Dr. Young, could you take a stab at answering that first, and perhaps Dr. Behrens?
Sure, thanks a lot. I think there are more questions than answers, unfortunately, for this group of patients, and continue to have significant variation in care, really dependent on your threshold for worry for potential poor coronary outcome. So really, that is the basis of the concern, is that the potential for poor outcome exists in all groups. And Mike really showed it beautifully in his wonderful talk looking at the epidemiology of the disease. And it's really much of the work, both clinically and in research right now, is to try to identify these identifiers of those who are at high risk for poor coronary outcome, and to really also identify predictors of treatment response. So with only preliminary data right now, the issue has been really trying to learn and borrow lessons that we've learned in Kawasaki disease. And really, this is the basis of a lot of the worries of really balancing the risks and benefits of treatment with no treatment, and what your threshold of concern is. And because of the ongoing reports, both formal as well as informal, of poor coronary outcome in children that seem to have a milder version of the disease, it has really guided some of the rationale for treating these children. Interestingly, these children also, at least in our institution in Toronto, seem to look similar biochemically than the children in the other ends of the more severe spectrum, whether they're presenting with shock or really classic Kawasaki features. And ultimately, as they evolve in their disease course, they develop significant thrombocytosis, really echoing what we see in Kawasaki disease. So although the jury's out, we have had a low threshold for treatment at sick kids, and we do treat these children much like others with Kawasaki disease and give them IVIG and antiplatelet therapy with aspirin.
Dr. Behrens, do all patients with MISC require treatment?
I mean, so it's a loaded question in that, you know, in a sense of like having data to back up any statement. I don't know. So I think, as everyone has said, in our hand is forced because we've got sick kids in our units, and so we need to deal. So I think we're all making our best guess, as has been pointed out multiple times. I think our experience has been that if you identify and treat earlier, kids tend to turn around quicker and easier. That kids that have, either because they had delays in presentations or because it had been more difficult to sort of pull the trigger, sick kids just get sicker. And I think, you know, the first line therapy, and I'm not going to stake a claim on what the right combination is, but some combination of IVIG and steroids, you know, is probably, I think, as Ray sort of mentioned, in the grand scheme of things, not particularly high risk, and the risks that those medicines come with can be mitigated with other interventions. There was somebody just put up a question about what do we do about kids that still might be bacterially infected, and I think, you know, you can cover somebody with antibiotics and give them steroids at the same time. So I think that we have erred much similar to what Ray has described on the side of, if you think you have MISC, you're getting some kind of therapy. We have kind of a stepwise thing at SHOP where we do IVIG first and then steroids, and that may be more historical than anything. But I think that it strikes me, just based on our experience in Philadelphia, that the benefits of trying to stop the inflammatory cascade earlier likely outweighs some of the issues.
And given what you said, Dr. Young, earlier, is you're thinking about the rationale behind the use of IVIG is really based on the resemblance to Kawasaki's and really protection for the coronaries, or are there other areas that are driving a rationale behind the use of IVIG?
Again, I think many of the lessons are borrowed from Kawasaki disease, given the lack of data that we have to be able to guide kind of a de novo generation of data. I think time will tell, and as Lauren mentioned, first off, this is really, the guidance is going to be evolving as we have more data. But you're absolutely right; it's mainly borrowed from Kawasaki disease, borrowed from the knowledge that we know that hyperinflammation responds well in Kawasaki disease to IVIG. In fact, MAS originally, before biologics came along, responds well also to IVIG as well as steroids. So I think there's a lot of good reasons that it responds, whether it be the soluble mediators of inflammation that IVIG tackles, or the cell surface receptors that it binds and the signals that it sends in. All of those are important components, I think, in the equation, and time will tell. And research, the key is really to understand then how best to pick the children who are going to respond to IVIG versus the children who are going to respond to steroids, versus those who require much more intensive upfront intensification of their therapy.
What's the dose of IVIG? Lauren, could you and Kevin in his cardiology KD hat, could you take a stab at that? What's the dose?
So as Ray said, most of this is based on what we know about Kawasaki disease. And typically the dose for Kawasaki disease is 2 grams per kilogram. So there's a couple of points to think about. So not all centers are going to have access to all the IVIG that they need. And so at our center, we work really closely with pharmacy to have an idea of how much IVIG is available and if we can give all the patients that we need 2 grams a kg. One option would be to, certainly for the MISC patients who present with Kawasaki disease features, to give them the 2 grams per kilogram. And if there's any type of shortage, patients that don't have the full Kawasaki disease features could get 1 gram per kg, though I think the 2 grams would be preferred. The other thing to keep in mind is that many of these children are much larger than our regular Kawasaki disease patients who are younger. And so giving 2 grams a kilogram to an obese adolescent can be quite a lot of IVIG. And so I think most centers are capping the dose at around maybe 70 to 90 grams. I'd be interested to see what other centers on the panel are maxing out for their IVIG.
Agreed. One other caveat is that it can be quite a big volume load for those patients who are presenting in shock. And so sometimes giving it in over 2 days, which isn't something we usually do in Kawasaki disease, may make sense to divide the dose in half just from a volume perspective, especially for those patients who are presenting in shock and where you're worried about aggressive volume repletion.
Given that IVIG is in limited supply and not present in some places, should we assign and use glucocorticoids first in people who don't have clear Kawasaki's criteria? Should we make some set of criteria and give them steroids first? Lauren or Ed?
I personally, I think that's difficult just because, as Ray and Michael Levin's group have shown, that patients without Kawasaki disease features can develop coronary artery aneurysms. And so I think our preference is, if at all possible, to use IVIG, certainly first. That's at our institution at Boston Children's Hospital. I'd be interested to hear what other members of the panel think.
Yeah, and the whole issue of what the effect of steroids in Kawasaki disease on aneurysms is a long and controversial issue. There's a train of school of thought that thinks unopposed steroids, so giving steroids without IVIG actually worsens aneurysms. Although a lot of the Japanese data now suggests that steroids are quite protective. So I don't think we know, even in Kawasaki disease, much less in MISC, what the effect of steroids, particularly steroids without MISC, is on coronary artery outcomes.
And what dose of glucocorticoids in MISC?
We're starting at 2 per kilo in a patient. If they're stable. If they don't respond to that, we have had some patients who we've pulsed 30 per kilo up to 1 gram for 3 days.
and agree that if you have life or organ-threatening disease, we have absolutely used the higher dose, as Jay was mentioning, for 30 per kilo up to a gram, has been for those children that have more severe disease.
And I see in the chat, just to clarify, that's Solumedrol or prednisone.
I want to get to the anticoagulation. We have a lot of other questions, but there have been a lot of questions in the chat as well. Maybe we could start with Kevin, Dr. Friedman, telling us, the thoughts on which patients should be receiving aspirin, which should be receiving unfractionated heparin or Lovenox, and which might need both.
Yeah, it's a tough question. There's absolutely no data. We have some first principles, which we know that certainly adults with similar hyperinflammatory conditions associated with COVID are seeing a tremendous amount of thrombosis. A lot less in kids. I think Adrian's paper reported, that's the only paper I've seen report thrombosis, and it was about 4% of patients. So we do know it's possible. We know their coagulation panels are markedly abnormal with really high fibrinogens and very high D-dimers, as well as very activated platelets. So a practical approach, which we've used, and I think is the best we can do, is to use antiplatelet dosing of aspirin, 3 to 5 milligrams per kilogram per day, in those patients who are not thrombocytopenic and have no other specific increased risk of bleeding. So aspirin in most, especially those with any coronary artery changes like you would do in Kawasaki disease or KD features. And then to titrate the degree of anticoagulation to the patient's individual risk factors. So in patients without bleeding risk factors, we've been pretty liberal in using at least prophylactic dose of Lovenox during the hospital stay, and have used therapeutic dose of Lovenox in those who have any sign of LV dysfunction, coronary artery changes, or we've set up arbitrary D-dimer criteria. Most people have used either D-dimer above 3 or 5 to suggest need for higher level of therapeutic anticoagulation. But admittedly, there's no evidence for those. And fortunately, at least my reading of the literature is thrombosis has been amazingly rare in children compared to adults with this disease, although we certainly think they're at risk given their coagulation profile.
Kevin, can I just ask you to clarify? I heard you say aspirin should be used in most. Should aspirin be used in all patients with MISC?
I think this is my personal opinion, there is no data for this, but I think antiplatelet dosing of aspirin of 3 to 5 milligrams per kilogram is completely fine as long as they're not significantly thrombocytopenic, say platelets below 60 or 80,000, or some other specific bleeding risk factor. We've used a tremendous amount of low-dose antiplatelet aspirin in cardiology and Kawasaki disease, and we know it's very, very safe. So I think it's a reasonable first step in almost all patients, except for those with specific risk factors against it. And I definitely would use it in all patients with Kawasaki disease features or any coronary artery changes, or for that matter, LV dysfunction.
And Dr. Mehta,
I was just going to add on to what Kevin just said about that, is that we do have some patients who don't have coronary changes at discharge, but then do develop them at follow-up. And so maintaining them on low-dose aspirin, even after follow-up, or even after discharge, it makes sense.
And Dr. Mehta, when do you use IVIG alone? When do you use glucocorticoids alone? Or do you always use them together?
We have had some patients who we've used IVIG alone if they're stable, if they don't have organ or life-threatening disease. We will just start with IVIG, or if we haven't established the diagnosis, like I mentioned, and ruled out bacterial causes. If there's anything, if they're any sort of life or organ-threatening disease, we'll jump to steroids at that point, or if the degree of cardiac involvement is substantial, then we'll add on steroids to IVIG at the outset.
And do you change your therapy if they have an enlarging coronary aneurysm already? Is there a change in therapy if they have an enlarging coronary aneurysm?
Nobody knows the answer to that, but we personally have added additional therapy because that's what we would absolutely do for Kawasaki disease. We believe strongly additional immunosuppression helps coronary outcomes in Kawasaki disease. So that would either be something like infliximab, anakinra, or more simple steroids. But again, there's no evidence. There's no definitive evidence for that.
We're running close on time, but Avina, I'm going to turn to you. One question for Dr. Mehta. resource limited environments. What is your recommendation?
This is a tough question, and this is actually something that Lauren and I have been talking to the ACR about. Is that should we modify this guidance for resource limited environments? And I think it's an ongoing discussion, and I wish I had a good answer for you, but I think certainly steroids are probably more available than IVIG, and so it is something you consider. But there is the concerns that Kevin had brought up about unopposed steroid use, and so I don't necessarily have a great answer there. I don't know if anyone else does.
Jeff, before we close this out, I'd love to hear Dr. Barron's thoughts on what drives us to move to other biologics like anti-cytokines. And obviously we don't know what's the best one yet, but what are the pushes to decide to go beyond the glucocorticoid and IVIG treatment?
Most of the kids that we have treated at CHOP with steroids and IVIG, you see a response probably within 24 to 36, at most 48 hours, both in terms of cardiac and inflammatory measurements. So if we're not seeing that, then we automatically think it's time to move on. And we have tended to move on either by increasing the dose of steroids, so going from that 2 per kilo to the magic 30 per kilo pulse, and or adding anakinra. So it's at that point in time that we're using anakinra, which I don't know. Again, it's like this best guess philosophy, right? Because it somehow sort of looks maybe a little bit like MAS and maybe a little bit like other sort of systemic inflammatory diseases in which we'll use anakinra. And I can't say that, I can't tell you that that's even worked or that's rational, but that's just sort of what we're doing. That's how we're using it. It's probably as rational as picking IL-6 blockade or as picking infliximab. But so that's what we've settled on at CHOP. I mean, it's literally, there's no more evidence based in that.
And Vinay, turn to you for some questions from the chat that we haven't addressed.
Jeff, I think there were several questions about some practical things about sequencing. So wondering if maybe Jay or Lauren could comment on, is there any reason if you give IVIG first or anakinra or infliximab, is there any impact of a different sequence of giving them? Any rationale behind giving IVIG first?
I think in MISC, really the rationale of giving IVIG first is based on extrapolation from Kawasaki disease and protecting against the development of coronary artery aneurysms. We know that that is the best medication to do that. We also know in MISC that patients, again, that don't meet full Kawasaki disease criteria can develop coronary artery aneurysms. So at our institution, we do give IVIG first. And as Ed mentioned, after IVIG, and often if the patients are in the ICU, steroids, the response is usually quite brisk. Within 24 hours, the patient's turning around. And if that's not the case, that's also when we add anti-cytokine therapies.
Great. And then the second thing that has come up is kind of the biomarkers like procalcitonin or D-dimer. What is it that kind of directs you to go from a prophylactic dose of anticoagulation to a treatment dose? And then again, are there any biomarkers that help you decide when to change back from a treatment dose of anticoagulation to a prophylactic dose?
I think Kevin might be good for that question.
We don't know. I mean, we've usually done treatment full dose when patients are sick in ICUs with evolving LV dysfunction or risk for coronary changes, and then switch to prophylactic dose as during inpatient stays. Typically, a lot of people have used D-dimers criteria cutoff and used either 3 or 5 as a D-dimer to treat with therapeutic dose Lovenox, and then to switch to something like apixaban or even just prophylactic dose Lovenox after that. And then most patients have just gone home on either aspirin unless they have some specific higher risk category like large aneurysms or ongoing dysfunction.
Aspirin for how long, Kevin?
We've just extrapolated from the Kawasaki disease literature, and like Lauren and Jay mentioned, there have been rare cases of later coronary artery aneurysm. So typically, we think in KD, if you're followed up somewhere around 3 or 4 weeks post discharge, and you have a normal echo at that point, you're kind of in the clear. And I think the same would apply for MISC. So typically, we've kept aspirin on for those kids who have normal echoes at 3 to 4 weeks. Stopped it then longer if there's coronary artery changes.
And then just before I turn it back to you, Jeff, to finish up, is there any rationale or has there been use of plasmapheresis or cytosorb or other extracorporeal therapies to remove remove the antibodies?
We haven't used cytosorb in MISC. We do have it on hand for acute COVID infection at CHOP, but haven't had to use it at all for MISC.
One last question I see in the chat here from Jose. Is there any laboratory difference between MISC and a generalized autoimmune vasculitis?
I think a couple lab markers I think have been really helpful in guiding the diagnosis of MISC. Is one of the things that we see pretty often is a really combination of a very high CRP and high procalcitonin, and a CRP that's often above 20 and a procal in the 10s, which we don't tend to check procal in autoimmune vasculitis, but certainly we don't tend to see CRPs that high there. And then the hyponatremia, the lymphopenia, thrombocytopenia, I think have been really helpful, and those aren't things that you necessarily expect to see in autoimmune vasculitis.
Well, I know I speak for the entire audience when we thank you all for joining us tonight and sharing with us your knowledge. The guidance document from the American College of Rheumatology is essential for us practicing. We all know that you're dealing with limited information, but at least it gives all of us a construct to follow. It's rational, and we have no doubt that it will evolve. And so we support and agree with it, making it a living document.